Thank you.
Good evening, everyone. I'm Dr. Nirukshi Fernando, and I'm pleased to serve as the moderator for today's session. It is my pleasure to warmly welcome you all to this CME program organized by the Women's and Children's Affairs Subcommittee of the College of General Practitioners of Sri Lanka. A few announcements before we begin. Kindly keep your microphones muted throughout the session. Please don't share your email addresses in the chat box. The e-certificates will be sent to your registered email address within 2 weeks. You are welcome to post your questions in the chat box during the lecture, or you may unmute and ask your questions during the Q&A session at the end. Today's topic is smart prescribing in mothers and children, tackling infections in the era of resistance. This is a very timely and important topic, particularly in the current era where antimicrobial resistance is becoming a major global health challenge. It is also very fitting that we are conducting this program today as we celebrate International Women's Day, highlighting the importance of safeguarding the health of mothers and children through responsible and evidence-based prescribing. It is indeed a privilege to introduce our speaker for today, Dr. Kushlani Jayatilleke, consultant microbiologist at the Sri Jayewardenepura General Hospital and honorary senior lecturer at the University of Sri Jayewardenepura. Dr. Jayatilleke obtained her MBBS from the University of Colombo and completed her diploma in MD in medical microbiology at the Postgraduate Institute of Medicine, University of Colombo. She has extensive national and international experience in infection prevention and antimicrobial stewardship. She is a member of several expert groups of the World Health Organization, including the Technical Advisory Group on the Aware Classification of Antibiotics and the Technical Steering Group on Infection Prevention and Control. She has also contributed to the development of several important WHO guidelines related to infection prevention, antimicrobial resistance, and emerging infectious diseases. At the national level, she serves on the National Advisory Committee for Combating Antimicrobial Resistance under the Ministry of Health, Sri Lanka, and has played a key role in developing the National Antimicrobial Stewardship Program and Aware Guidelines in Sri Lanka. Dr. Kushlani Jayatilleke is also a respected academic trainer and examiner for undergraduate and postgraduate medical programs, supervising many MD and PhD research projects. She has been a resource person at many international conferences, including the European Society of Clinical Microbiology and Infectious Diseases Congress, and has received several research awards, including the President's Award in Sri Lanka. With a vast experience and expertise in microbiology, infection prevention, and antimicrobial stewardship, we are indeed honored to have her with us today. Without further delay, I would like to invite Dr. Kushlani Jayatilleke to deliver her presentation. Madam, the virtual floor is yours.
Thank you very much, Nirukshi, for that very extensive introduction. I think so. Anyway, thank you very much, and good evening to everyone. And happy Mother's Day, of course. It's the Women's Day, International Women's Day. So timely and a very appropriate topic today. So SPART, prescribing in mothers and children, tackling infections in the era of resistance. Today I will try to cover some areas about the challenges and about the antibiotic resistance, what do we mean by this era of resistance and how big the problem is, and what we can do about it, and some special mention about mothers and children. So antibiotic resistance, we know that antibiotics, which are very useful group of medicines, and antimicrobials, it's a broader term where maybe antivirals, antifungals are also included. So we talk more about antibiotics because that's the common group of antimicrobials that we use. So what we understand by this resistance is that these microorganisms are now developing resistance. That means they are not inhibited or killed by these antibacterial or antimicrobial agents at the concentrations of this drug achievable in the body after normal dosages. So that is the definition of antibiotic resistance. So as we, I think, have learned in our undergraduate days, there are two types of resistance: intrinsic resistance and acquired resistance. So intrinsic resistance is like from the beginning, there are certain antibiotics which are not working against certain organisms. Like, for example, we know that penicillin is not effective for Pseudomonas. That was anyway like that. So that we can't do much about. But what we are worried about is this acquired resistance, which means that the antibiotics which were effective for certain bacteria are now becoming ineffective. So they are now developing resistance to these antibiotics. So this is the worry that we are having. So if you take a bacterium, it's as you know, it's a single cell with a chromosome in the middle. And then you have there are different mechanisms of resistance that they can develop. So first thing, I think a common one that we know about is this drug inactivation with enzymes. So they may develop some enzyme which can destroy the antibiotics. The blue balls are the antibiotics. So here you can see that green enzyme can bind to the antibiotic and destroy it. So one example would be beta-lactamases that you may have heard. So there are some even can destroy extended spectrum beta lactamases, which can even destroy third generation cephalosporins. And even now we have carbapenemases. Like even our best drugs that we have, the carbapenems, imipenem, meropenem, can be destroyed by enzymes, which are produced by some bacteria. Then the other mechanism is that they can change their molecule, the structure of the molecule to which the antibiotics bind, like in MRSA. In the Staph aureus, when they become MRSA, they change the molecule to which the antibiotics are bound. So therefore, no beta-lactams are effective for MRSA because they can't bind to this receptor. The beta-lactams that are currently available in Sri Lanka are not effective, but there are a few new ones which are effective now. But so this is a change of the target molecule. Or sometimes they change the cell wall so that the antibiotics cannot enter the cell and destroy the cell. Or sometimes the antibiotic, even if they come in, they can be pumped out by the cell, called efflux pumps. So these are different mechanisms that they can have to become resistant to these antibiotics. So at genetic level, what happens? How does it happen? Now we know that bacteria multiplies very fast. So if you take one single bacterium, so the left-hand corner, you can see there's one bacterium, which they multiply very fast into millions of bacteria in any given time. So if this is a population of bacteria in your intestines, we know that when they multiply very fast, there's a potency to have little bit of change in their DNA. That's a natural phenomenon. So that mutations can develop in their genetic material. Then if one of these mutations is coding for an enzyme which can destroy an antibiotic or changing the molecule to the target molecule for an antibiotic, that may become that bacteria will become resistant to that particular antibiotic. So now here there are two bacteria which have changed their genetic material. The yellow ones, which have that red part which is changed. Now, in a normal population of bacteria, since there's a large number which are sensitive, even one or two of these mutant bacteria may not survive. They may have their own, competition, and they may not survive. But in case we use this antibiotic, we make the this population of bacteria exposed to this antibiotic. Say that we are having this is a bacterial colony in our intestines, and now we take some antibiotic. The susceptible bacteria will die, but the two resistant bacteria will remain. So that's the third picture that we have shown here. Then what will happen is this resistant bacteria now doesn't have any competition from any other bacteria, and therefore they will multiply into a population of antibiotic resistant bacteria. So if you have a resistant flora in your intestines, next urinary tract infection of when you get it will be with this resistant bacteria. So this is how the problem develops. So this is why, like we tell, not to use unnecessary antibiotics, because if you use antibiotics, you are disturbing your normal flora. So the good bacteria that is there may be replaced by resistant bacteria. So which are within inverted commas, because we need that normal flora. So we don't want to destroy it nowadays, where there's much evidence about even non-communicable diseases being related to the microbiome in the gut. So therefore, we should not disturb our gut. We should make more and more good bacteria multiply in our gut, and we should not use unnecessary antibiotics. And also these resistance can be there in plasmids, which are extra chromosomal DNA, which can be there in bacteria. So in that situation, they can be easily transmitted to other bacteria through different means. So the first thing that they have shown here is like through pili, sometimes 6 pili we call, they can transmit the plasmids to another bacteria with that resistance gene. That is conjugation. Then through the phagers, which can the viruses which can infect bacteria can also transmit this genetic material. And also when the bacteria dies, they can another bacteria can take up the free the chromosome, the DNA. So therefore, this all these mechanisms can change resistance genes from one bacterium to the other. And in the population, if somebody is taking antibiotics, now like this Mr. George here on the right-hand side, then when he takes antibiotics, his gut flora becomes resistant. And it will go to, like if he goes to the healthcare facility, it can, if he's a patient in the hospital, he can spread it to the other healthcare workers. And if they don't wash their hands, they can spread to the other patients. And also in the community, he can spread it to others in the family, or even the same thing happens when you give antibiotics to animals. For different reasons, animals are given antibiotics, and that can come through the food chain to humans. Even the environment can get polluted through the excreta of humans as well as animals, because we know even our excreta goes to the environment. The river water can get, rivers can get contaminated. So therefore, the antibiotic resistant bacteria and their genes can spread throughout the population. When one person takes an antibiotic, not only that his or her flora becomes resistant, but it can spread to others as well. So that is why, unlike any other medicine, now we know that any medicine, if somebody takes a medicine, there's a risk of side effects and adverse drug effects. But antibiotics or antimicrobials, if you take systemically like oral or IV, not only it affects your body, but also it can affect others in the community and the environment. So therefore, that is why the antibiotics or antimicrobials are an important group of medicines, because it doesn't only affect the person who takes it, but the whole population. So what is the magnitude of this problem? If you know that the first antibiotic, the penicillin, was discovered around 1940s, maybe started in around 1940s, the use. And then the sulfonamides were used before that, but the actual antibiotic penicillin was, beta-lactams came in 1940s. And then from there onwards, there were different groups of antibiotics which were discovered and used. But after 1960s, there's a big gap. Now, these blue boxes on the top shows the development of new antibiotic groups. So until about 2000, there was a innovation gap. So there were no new antibiotics coming to the market. Even now, there are few coming as like maybe new antibiotics per se, but also mostly they are some combinations like beta-lactamase inhibitors and so on are now coming to the market. But they have very, very slow production, and also the effects are very narrow. Some of them are effective only for certain resistance mechanisms. So you can't just give it for anybody empirically. So unlike carbapenems, which have a very broad cover. So therefore, there are limitations in the new development of antibiotics is very slow. And if you look at the bottom, you can see the green boxes, which show the different resistant mechanisms that they have developed. And also you can see the boxes are continuing. So there are different resistant mechanisms developing to these antibiotics when they are used. And this is a prediction that they have made through the data analysis that by 2050, about 10 million people will die of antimicrobial resistance, which would be even more than cancer worldwide. And in the same report, they predict that the highest number of deaths would be in Asia, where we live. So we can argue, okay, because Asia has a very large population with China and India being there, that may be why we have more people dying. That's possible. But if you really look at this data, now this is a link that you can access data, global data. This is a WHO website on global laboratory-based antimicrobial resistance surveillance. And in that, if you look at the summary, they have nicely given data from different regions. Even Sri Lanka is part of this surveillance. We send data from 25 sentinel sites through our Ministry of Health. There's a focal point for antimicrobial resistance, who is the Deputy Director General Laboratory Services. Through him, we are sending the data to the global platform. So this is an example. Now, Klebsiella pneumoniae, which is a common pathogen, and this is in blood cultures. What we have got for the resistance to third generation cephalosporin, in Sri Lanka, 67% of our Klebsiella pneumoniae were resistant to third generation cephalosporins. But in Asian countries, now you can see India is worse than us. And but Nepal has only few numbers reported, so therefore maybe the number is not very accurate. But so this is not that good. I mean, 67% of our Klebsiella pneumoniae are resistant to cefotaxime, ceftriaxone, cefixime, and so on. So the third generation cephalosporins. So if you look at this with compare with this, the European region. Now look at the data from Switzerland. It's only around 10%. The same data, third generation cephalosporin resistance in Klebsiella pneumoniae. United Kingdom, the last one, is around 12%. And again, you can see Sweden is around 6%. So how good their resistance is. That means how low the resistance is. You can see. Why is this difference? Because they have good regulations in prescribing, and the guideline-based prescription is followed, and they can't just buy any antibiotic over the counter. So with this strict regulations and implementation of quality measures, they have kept the resistance very low. And also the infection control measures. They isolate patients who are having resistant organisms. They have facilities to do that. So they take precautions to prevent spread of antibiotic resistance. So this is another example. This is actually in Sri Lanka, from the same database, global surveillance. They have, now you know about sustainable development goals. So one such goal is to look at the antimicrobial resistance. One indicator is E. coli in blood cultures. Again, from Sri Lanka, third generation cephalosporin resistance. It was more than 60% to start with, and even now it's around 60%. So over from 2018 to 2023. So we have been submitting data for these several years now, since 2018. So now if you look, they have given this nice graph. You can see a little bit of downward trend, maybe with what we are doing and what we are trying to achieve. Like so many activities are going on with this National Action Plan and all. So anyway, a little bit of low trend is there, but still it's around 60%. Same thing in the United Kingdom, E. coli third generation resistance in the E. coli, it's around 10%. See, but what it was 60% in Sri Lanka is now 10%. But here the trend is a little not that good. It's going up. I don't know whether it's a real trend. Then the other important bacteria, Klebsiella pneumoniae. Now I showed the 2020 data. Now 2023 data again. In Sri Lanka, you can see the carbapenem resistance is around like 30 to 40%. Imipenem, meropenem at the bottom, you can see. Cefotaxime, ceftriaxone close to 60%. So here again, the United Kingdom carbapenem resistance is very low, below 5%, around 1 to 2%. But cefotaxime, ceftriaxone around again 10 to 20, between like 10 and 20%. So this is the situation. We are in a very bad situation. Here you can again see Staph aureus. You know MRSA, methicillin resistant Staph aureus. Again in Sri Lanka, the trend is like not that bad, but if you look at the resistance rate, again it's around close to 60% to start with, but now it's around 50%. And in the UK, it's again around 10%. So we are not that great. So it's pretty bad, the situation. So will we have a miracle lane or is it a dead end? So what can we do about this? So one good example that I saw is like just in Denmark, when they banned the use of antimicrobials in the broiler. It's not in humans. This example is from broiler chicken, where you can see now this bar chart shows the substance used. The evaporin is an antibiotic that they have used for growth promotion, and it had now come down. The use had come down by 1996, and you can see the resistance in the broiler, the bacterial Enterococcus faecium and fecalis resistance in the broiler gut had come down to 0. So if you stop using any antibiotic, you can make the resistance come to 0. But we can't do that. We need the antibiotics. We need to use it. So but what we have to learn here is stop unnecessary use. Use it only when necessary. But when you are using it, how to use it is also important. So this is an example where you can see that this is a graph showing the concentration of the antibiotic in the blood versus the time when a dose of antibiotic is given. Now, the smallest peak here is if you give a very small dose, you can see a small spike may come up. The maximum will be very low and it will come down with time. So you can see the first the line that shows the minimum inhibitory concentration, MIC. That is the minimum inhibitory concentration of this population of bacteria, which is shown in your right-hand side. So that population, again, there are two red ones and all the others are green. So the green ones are the sensitive ones and two had become resistant by mutations, we would say, like what I showed earlier. So these two will have a higher MIC. Minimum inhibitory concentration would be higher when it's resistant. So if you give a very small dose and the peak is the first one, the very low one, lowest one will have no effect on any of the bacteria because it is lower than the MIC of the population. So that will not kill any bacteria. But if it goes above this MIC, it will kill the sensitive bacteria, but still the resistant bacteria may remain if you increase the dose to certain amount. So there's another line on top which is saying MPC. MPC is the mutant prevention concentration. So mutant prevention concentration is the concentration which you have to achieve to kill the mutants, which have a higher MIC. So if you give a very high dose of antibiotics, you will get a high peak, and the Cmax, that is the maximum concentration, will achieve adequate levels to kill the mutants as well. So this is what we should try. We should try to kill the mutants. Therefore, the lower doses should not be used, since they can promote resistance like in the second one. So it has to be appropriate doses. You have to use appropriate doses of antibiotics when you need it. So because some people think like, okay, some doctors think, since now this one doesn't have very severe infection, so we would give the half dose or whatever, not the recommended dose. Then what you are doing is you are making unnecessary development of resistance and promoting the resistance development. So don't do that. Give the correct dose. So Global Action Plan was developed by WHO for combating antimicrobial resistance in 2015 and adopted it in the globe. And then with the World Health Assembly. And based on that, Sri Lanka also developed a national strategic plan for combating antimicrobial resistance in 2017. This had 5 strategic objectives. So this is the Global Action Plan and the strategic plan that we developed for 5 years from 2017 to 2022. And in that, the 5 objectives were improving awareness and understanding by education and training. So different categories has to be trained on this, and actually the awareness of even including the patients should be aware about the problems and how to take antibiotics and so on. And also to strengthen the knowledge about this, surveillance and research was important, reducing the incidence of infection by infection control activities is also important, and also it prevents spread of antibiotic resistance if you practice good hygiene, hand hygiene, and so on. Also, optimizing the use of antimicrobial medicines. That is what we call this antimicrobial stewardship. Now, most of our hospitals have started antimicrobial stewardship programs by documenting and measuring antibiotics and auditing and all that, which is very important because we want to control, in the sense we don't want to use unnecessary antibiotics, and we want to optimize the way we use the antimicrobials. So the 5th one is the sustainable investment for new medicines, new diagnostic tools, vaccines, and other interventions. And since we have now completed the first 5 years, we had to update it, and we have published the next 2023 to 2028 strategic plan for Sri Lanka. And in that we have included 2 more points additionally. The first one is to advancing national response, to make it like the governance structure to be strengthened, and also to have environmental safety. So why is prescribing in mothers important? Now, coming to the problem of mothers and children. Now, we know that during pregnancy, numerous anatomical and physiological changes occur to meet the increased demand in the pregnancy. So in that, you may get, the patients get cardiac output increase, and the blood pressure can vary, like they may decrease in the first, maybe up to about 24 to 26 weeks. And then all this will affect the drug pharmacokinetics. And again, slow gastric emptying may also delay the absorption of the oral medicines. So there are so many things that are happening, like increased cardiac output, reduced blood pressure, increased plasma volume. So there may be different volume distribution may be different, and plasma drug concentrations can be low. And again, plasma protein binding can be altered. Absorption can be reduced. Drug clearance can be increased. So there are so many things which can happen in a pregnant lady. So apart from that, the other worry that we have is the fetus. So how much of this drug will go to the fetus, and how will it get affected? So this is also, there are so many factors that can influence the drug, whether how much of the drug will go to the fetus. Now, FDA in the US, they have earlier had several categories for pregnancy risk, like A, B, C, D, and X, based on the evidence and the risk that they have. But currently now they have removed this classification, and now they have a different sort of they sort of talk about pregnancy, labor and delivery, and nursing mothers as use specific populations. Under that section, they are describing it rather than this categorization. So this is actually this, I have taken this from a very nice app which you all also can use, because antibiotic, I said we have to use the correct dose. So there are so many factors which we have to consider. So it's not easy to remember all the dosing, especially in patients who are having renal compromise situation, or some other maybe physiological conditions. So it is very important that we have a handy app in hand. So this is actually I am using the Sanford app, which is a US based app, but it can be downloaded by paying about 4,000 odd rupees annually, and it gets updated with latest guidelines, and it gives the evidence as well and calculations. The lot of very user friendly app is there. So in that, they have now given a table like this for the risk in pregnancy and using the lactation period. So if you look at amoxicillin and cloxacillin, there's not much of a problem in pregnancy as far as we know now, because they are penicillins, which are usually safer in pregnancy than other antibiotics. But first thing is to avoid unnecessary antibiotics, especially in pregnancy. No drugs should be used if possible. But if it is necessary, I mean, penicillins are a group of antibiotics which is safer in pregnancy than others. And lactation also, they say, okay, milk concentration is low and adverse effects not expected, but you have to monitor the GI side effects in the infant. So, cefuroxime and amoxicillin clavulanate, again, beta-lactam antibiotics, again, safer drugs in pregnancy. So, if you look at the clarithromycin and azithromycin, they are macrolides. There is a little contradicting evidence about this group. Some studies have shown that there are some abortion risk and high risk in like anomalies and all. But in some studies, they have said there's nothing major reported, no difference. So, but it is very important, better not actually give these if possible. So use with caution in azithromycin, which is a very common antibiotic, I think used in the primary care, because it's a very easy to administer and very, I think, anti-inflammatory effects are there. So people just use it very freely in oral form. But again, you have to be careful in pregnancy. Quinolones, of course, you have to avoid. Ciprofloxacin and levofloxacin should be avoided in pregnancy, and breast milk, breastfeeding mothers as well, if possible. But what they say here is like you can avoid breastfeeding for a few hours after administering it. So, but I think best is to avoid if possible. Clindamycin, again, there's no evidence of toxicity with second and third trimester, but insufficient data for first trimester use, and avoid if in lactation if possible. Nitrofurantoin, of course, is another one that you have to remember. This should be avoided in the later stage of pregnancy, during like labor or around that period. So 38 to 42 weeks of gestation is the time that you have to be careful when using. You should not use nitrofurantoin in this period, because this can cause hemolytic disease of the newborn. Especially in G6PD deficient babies, this should not be used, and also infants less than 8 days of age. So lactation mothers also should not be given in this situation. But now this is an audit that we carried out in a tertiary care hospital, where 100% of patients were on antibiotics. So children are given a lot of antibiotics, especially in hospitals. So sometimes, even though they have a diagnosis of dengue or influenza like viral picture, some believe that still antibiotics help, but there's no evidence for that. So that is the problem. So this is a national guideline which is available in the again the link is here, which is in the Sri Lanka College of Microbiologist website. Empiric and prophylactic use of antimicrobials, which was updated in 2024. So again, there's a chapter on prescribing in pregnancy and lactation, the chapter 5. And chapter 26 is infections in pregnancy, and chapter 27 is infections in children. So this is part of this prescribing in pregnancy and lactation, where first sentence is antimicrobials should be prescribed to women during pregnancy only if the expected benefit to the mother is assessed to be greater than the risk to the fetus. So we have to always think of this, because the data may not be complete, and there's always a possibility of having side effects, especially to the fetus. And they give, again, the considerations are given here for pregnancy and lactation. So this is available for anybody to download, but it's not very user-friendly like the app. But if you want, you can take the tables, prints or something, then keep. So again, for the children, empirical therapy guidelines are given in this national guideline. Then diagnostic stewardship is also important. That means you have to use the correct diagnostic methods. First is to get a detailed history and examination for clues. So there are certain things you can get in the history and examination. If you properly do this, you may get a clinical diagnosis, which would be very useful to decide whether antibiotics are needed or not. Then something like CRP would be useful, and maybe cultures, if you can collect a sample without contamination. That is a problem with children. So mothers, of course, yes, you can take, but for children, it's very difficult to take a good sample without contamination. So bag urine is invariably contaminated, especially in female babies, and also even in male babies. It's very difficult to get a sample without contamination. And in that situation, the other important thing is the transport. Even in a hospital, sometimes we see that there's a big delay in transporting the specimen of urine culture collected from ward to the lab, which is wrong. I mean, you can't keep a sample overnight on a bench and send it, because invariably there will be a little bit of contamination, and that would multiply into a very big colony count, and then we would be reporting it as 10 to the power 5, more than 10 to the power 5 colony counts, and everybody would think it's a very important organism to treat. So therefore, please make sure that you collect the sample as much as possible with proper cleaning, and maybe a clean catch can be taken. But urine culture should be transported to the lab immediately, or otherwise it has to be refrigerated. And transport from far, if you have to transport for a longer period, the transport should be done in a proper packaging, like a insulated box in ice, rather than just in ice, like rigiform box, which can again melt. Ice can melt if you are taking it for a long, traveling from far. So therefore, it's very important to transport it properly. This AWARE classification this is a classification of the WHO. They have classified the antibiotic into 3 groups: access, watch, and reserve. And this they have an important book, which is called the WHO AWARE Antibiotic Book. In that, there are some nice infographics which you can use. Even you can even print and keep in your facility to refer. In that, they all nicely talk about different common conditions where antibiotics are not useful, and even if it is useful, what antibiotics to give. So that's a very nice book that you can refer. It's available in the WHO website. The link is given. So acute bronchitis is usually present as a persistent cough with or without mild fever. Almost all cases are viral and self-limiting. Patients should be informed that cough can last several weeks. So it's just that to please the mother or the patient, you should not just give antibiotics. You have to talk to the patient, take some time and explain to the patient why you are not giving antibiotics. I'm sure most of the patients also don't like to take the medicine. Sometimes they say like, okay, we didn't want, but the doctor gave. But some patients, yes, they will think that antibiotics will make them better early. But you must explain to them that it doesn't do that, because if it's a viral infection, antibiotics will not help. So bronchitis is such a situation where the cough can persist. So you have to tell them that this cough will not go away within 1 or 2 days. Then you have to give some symptomatic relief. Yellow or green color sputum does not indicate bacterial infection. So antibiotics are not indicated. And clinical presentation can differentiate bronchitis from pneumonia. So this is very important as a doctor. We should diagnose clinically what this condition could be. So acute bronchitis is a self-limiting inflammation of the trachea and bronchi characterized by persistent cough with or without fever, usually caused by a viral infection. Antibiotic treatment is not recommended for acute bronchitis and should be avoided. There's no evidence of meaningful clinical benefit of antibiotics, and their use is not supported by available clinical evidence. So this is what you have to understand. This is all there in this AWARE book. Then acute otitis media again. Now we feel if it's otitis media, we have to give antibiotics, but what is the truth? Several bacterial and or viral respiratory pathogens are associated with acute otitis media. So there are, again, I'll show you some nice infographics, like the tables are there. So most cases of otitis media are triggered by infections with respiratory viruses. Respiratory syncytial virus, rhinovirus, coronavirus, all can cause a little bit of otitis media, which can be complicated by superinfection with bacteria. True. But you can't prevent infection by giving antibiotics. So that is not recommended. Only if there is a bacterial infection, you should give antibiotics. So most non-severe cases of acute otitis media can be managed symptomatically and do not require antibiotic treatment, especially in children older than 2 years. So even if you're giving antibiotics, what they recommend is amoxicillin for 5 days. Because the common pathogens like Streptococcus pneumoniae are usually sensitive to amoxicillin, and even Haemophilus is quite sensitive. So these are the common pathogens which you can get in the otitis media. So here, this is from that AWARE book. I said these are the way that, like, how they present. So very handy. You can have this printed in and kept in your facility. Very nicely given. Bronchitis, a summary is given, diagnosis, microbiology test, and imaging, what you can do if there are any. And then most likely pathogens list is also given, and treatment. So bronchitis, no antibiotics. And how they also give the doses, which is very important. Now, when you prescribe children, you must know that the dosing, I mean, we usually think like, okay, half dose of the mother or adult's dose is enough for this one or something like that. But actually, we should check the proper dose for children. It's not just the half dose of adult dose or something like that. So the doses are also given here. And also acute otitis media, when to give antibiotics and what to give is also described nicely in this uh, book. That is the antibiotic book of the AWARE antibiotic book of WHO. Again, acute sinusitis, again here they are saying mostly viral, but when antibiotics are needed, you can give amoxicillin or amoxicillin clavulanic. Then pharyngitis, again, this is also, it could be, mostly it is viral. We know that in most influenza, COVID, we had a lot of patients coming with pharyngitis. But how do we know whether it's a streptococcal pharyngitis, which is very important to be treated with antibiotics. You know that group A streptococcus infection can cause complications. So therefore, it is very important that we treat them with antibiotics. So how do we know whether it could be a bacterial infection? So cultures can be done, but it takes time to get the report, and that may be too late. Also, it may not be available everywhere. So this is how they have given, like with signs and symptoms, how you can suspect bacterial infection. If it is fever for more than 38 degrees centigrade, no cough is for like bacteria. Because if there's cough, it could be more like a viral, maybe pharyngitis along with a viral infection. So therefore, no cough is more like it's favoring bacterial infection. And tender anterior cervical lymphadenitis and tonsillar exudates are in favor of bacterial infection. So there's a scoring that they have given, and how to suspect bacterial infection and to treat, and what antibiotics to treat, and the doses are all given in this guideline. So you can refer again only amoxicillin or phenoxymethylpenicillin or cefixime. Cefalexine is recommended. Sorry, not cefixime, cefalexine, right? Clarithromycin is given as another option in case there's a severe allergy. But another important thing about allergy, now, that is also very important. Now most of these are beta-lactams, amoxicillin, clavulanate. People may say, I'm allergic to amoxicillin. But if you really go into the details, they would say, okay, I had a little diarrhea after taking amoxicillin, or little rash after. So that could be just a reaction, not an allergic reaction. It's a side effect sometimes. And sometimes, with certain viral infections like Epstein virus, if you take amoxicillin, you can get a rash. So we have to take this history carefully and see whether it's a real allergy or whether they are describing something else. Sometimes in these patients, if you really go into details, they would say they have been nicely taking amoxicillin clavulanate also. So there are certain controversial histories. Sometimes they don't know what happened. So it's unnecessarily we are avoiding the best antibiotic if there's a vague history of allergy. But on the other hand, if there's a history of allergy, we know that if we give this and something happens, then we are liable. So that is the problem we are facing. But it is, again, there's a guideline in this empirical antibiotic therapy book that I showed you in the College of Microbiologists, how to evaluate a history of allergy, which is also very important because we are unnecessarily labeling them as allergy, and sometimes patients are not given the appropriate antibiotic due to that. So this is the book that has this graph also. You can, there's a section on this allergy evaluation. You can check that. And also, now there's another section that I want to show. This is the prophylaxis. Surgical prophylaxis. So we know that there are, for certain surgeries, prophylactic antibiotic treatment is recommended. But it is for only certain surgeries, and there are different antibiotics which are recommended, and the timing of giving the antibiotic is important, and the duration. So there's this guideline again has a chapter on surgical prophylaxis, which you can refer. In that, nicely there's a section on gynecology and obstetrics. So you can see that so many procedures, they are saying antibiotic prophylaxis is not indicated. And even assisted delivery is one of them. So definitely for normal vaginal delivery, there's no need of antibiotic prophylaxis. Cesarean section, yes, there is cefuroxime or coamoxiclav as a recommendation, and alternatives are also given if there's a severe allergy. Hysterectomy, yes, but not for all other simple procedures. But what do we see? Now, this is an audit which we have carried out in a private hospital in Colombo, where there were 9 consultant obstetricians visiting this hospital. Only one had consistently not given antibiotics in normal vaginal delivery. All the others had given antibiotics, but interestingly, it was after delivery. So it's not a proper surgical prophylaxis, but they just give after delivery for 5 days or more. Even when the patients are sent home, they are given antibiotics. But they are lactating mothers. So what will happen to the fetus? All these antibiotics go to the fetus as well. So their flora will become resistant from the time they are born. So first, it's onwards, they are getting high doses of antibiotics for a long period, 5 days. So unnecessary antibiotic exposure to all neonates. So infection prevention and control is also important. Now, with all these problem we saw, we have to use antibiotics when they have infections. So if we prevent infections, we can reduce the use of antibiotics. So we know that in pregnancy, especially tetanus toxoid is given as 2 doses. And then mandatory screening is done for HIV and VDRL so that mother-to-child transmission is prevented in Sri Lanka. And also asymptomatic bacteriuria. Now that is an interesting topic again, because you know what is asymptomatic bacteriuria? That means the culture is positive, but the patient doesn't have symptoms. The urine culture becoming positive with more than 10 to the power 5 colony forming units in one particular organism, maybe E. coli or something, but patient doesn't have symptoms. Then why they have done it? Maybe because they had another infection in the past, they were asked to do a culture, or they may have been they are awaiting a cardiac surgery and they do a urine culture. But these are not indications for urine culture actually. So urine culture should be done only when they have symptoms. But in one situation, we recommend to do a screening urine culture, that is in pregnancy. In pregnancy, urine culture should be done, and if it is positive, we recommend to repeat it, because asymptomatic bacteriuria has to be confirmed with 2 positive cultures rather than just with 1 culture. If both are positive with the same organism, then you should treat it. Because in pregnancy, we know that there's a high chance of pyelonephritis and premature labor. And other condition where asymptomatic bacteria is needing treatment is if they are awaiting a genitourinary surgery, not any other or genitourinary procedure. In any other condition, asymptomatic patients should not be asked to do urine cultures. Even if they had one urine culture positive, urine infection, they should not be asked to repeat urine cultures just because they have had an infection in the past. So that is very important, because asymptomatic bacteriuria is common. It can happen in anybody. There can be a culture positive, especially in elderly people. But it doesn't mean they need treatment, and treatment is not helpful. There's no evidence that it will prevent infection. So therefore, only 2 instances where they recommend to do urine cultures on asymptomatic patients is in pregnancy and patients who are awaiting genitourinary procedures. So this is the national immunization schedule where, I think the first year of life you get like the OPV, the pentavalent with the triple and the hepatitis B and the Hib, and injectable polio, as well as MMR is given, and then the JE, the other things like MMRA I mentioned, then the other things like HPV is also now included. And again, you know that pregnant women are also given tetanus toxoid. So all this is in Sri Lanka. But in the UK, there are so many other vaccines which are there. Like meningitis, there are 2 vaccines now for meningococcal A, C, W, and Y, and meningococcal B. Then rotavirus has a vaccine, then chickenpox vaccine. All these are available in developed countries. So there are so many additional vaccines which may be useful, and the pneumococcal vaccine, very important. Still, we have not introduced it to our schedule. But I think if in the private sector, I think it's important to recommend to different groups if they can afford it. So there are so many vaccines like the pneumococcal, the pertussis, and like COVID-19 now, I think even might need more vaccines. But now, interestingly, people are attributing all the problems to COVID-19 vaccine. Because recently also I heard that when I think a child had died after a Guillain-Barré syndrome, and there was an interview with the mother, and at the last point was he was like the mother was asked whether the child was given the COVID-19 vaccine. So many years back, but still this boy was not given that vaccine. So it is because they want to try and connect this to the vaccine, but I mean vaccine can't is not the only reason for all these problems that we are having today. So therefore I think we have to promote vaccines as doctors, because the prevention of infections is the best way to go, rather than treating and making it, because you see even in the UK now the resistance is seem to be increasing, though it is at a very low level. So we have, someday it will come to a point that we may not have these antibiotics effective. So in the labor and postpartum period, again, you have to follow strict asepsis during the vaginal exam. I mean, maintain during the vaginal examination to prevent this puerperal sepsis, and also minimize the number of vaginal examinations, especially in case of premature rupture of membranes, and encourage immediately and exclusive breastfeeding. And talking to the patient and educating the patient is also important. So the public education here, this is in American Academy of Pediatrics. They have official news magazine. They are having a nice informative article where they say not every illness should be treated with antibiotics. So they say that antibiotics will not cure illnesses caused by viruses such as cold, bronchitis, and most diarrhea, ear infections, sore throat, and viral pneumonia, and so on. And antibiotics should be used only when a person has an infection caused by bacteria that will not go away by itself. Because even we know that some diarrhea which are caused by bacteria like salmonella may not need antibiotics. If they are mild disease, they may spontaneously resolve. So these illnesses, including severe ear infections, streptococcal sore throat, long-lasting sinus infections, or bacterial pneumonia or bacterial meningitis, may need antibiotics. So communication with the parents and the patients are important to explain why antibiotics are needed or not needed. So that has to be explained, and then probably they will understand. And allergy history is important to be taken properly. And which one is the antibiotic? You have to explain to the patient, because you may give a list of drugs, including maybe antipyretics, antihistamines, and so on. So if they don't have fever, they can stop the antipyretic or the antihistamine. If they don't need, they can stop, but not the antibiotic, because antibiotic, if they have been given like for a bacterial infection, there's a proper duration, maybe even 4 days, sometimes even 3 days, maybe for some it is just 1 day, like a cystitis, it may be even one dose is enough. But you must tell them that for certain infections, you may need to give it for a longer period. So that has to be kept told. This is the antibiotic you have to take. Even the pharmacist has the role to do that, but even doctor can explain, mark it and give, so that they can ask the pharmacist which one is the antibiotic, and they have to take it on time, correct dose, everything has to be told. So importance of taking it correct time without missing a dose, and duration needed for the infection, and possible side effects, and what to do when notice any of these side effects, you have to explain to the patient. So because sometimes you know that their antibiotics can have very serious diarrhea and other side effects which can even kill patients. You think Clostridium difficile is not here, it is there. I have seen some serious infections with Clostridium difficile toxin causing pseudomembranous colitis also in this country as well. But the problem is we don't diagnose it. Most of the time we don't have the facilities to test and diagnose, so we don't know. Even recently I had a patient who had just taken cefalexin, oral cefalexin, and she got diarrhea, and later C. diff was positive, and C. diff also, there are certain tests only detecting toxin. There are certain tests which are detecting toxin A plus B and the GDH antigen, which is important to test for, because sometimes the sensitivity may be low if you just test one toxin or even both. So therefore, it is important that we have this in mind when you are prescribing. So if there's a diarrhea, ask them to stop the antibiotic and come and meet you. You may need to first treat that before you go on to treat the proper infection. If there is a bacterial infection, you may need to treat, but you have to weigh the risk and benefit and decide, because best is to stop the antibiotic in that situation. So in summary, antibiotic resistance is a grave problem affecting Sri Lanka. Unnecessary use of antibiotics should be stopped. When indicated, antibiotics should be used according to the guidelines. The drug, the dose, and the duration is important to be considered. Prescribing antibiotics to children and pregnant and lactating mothers should be done with caution according to guidelines. Infection prevention and control is important to reduce use of antimicrobials and to control the spread of antimicrobial resistant pathogens. These are my references. Thank you.
Thank you very much, madam, for that insightful and informative lecture. It was truly a valuable and enriching session for all of us. The forum is now open for questions. If you have any questions or comments, please feel free to unmute yourself or post them in the chat box.
Yeah, I think someone has asked for the links. So I don't mind this being shared with the participants if it is possible, because then they
Okay,
can,
madam.
yeah, I don't mind sharing this.
Madam, there's another question.
Uh,
When should we give tetanus toxoid for children for wound exposure?
Yeah, but children actually they are getting the normal scheduled triple, so that pentavalent vaccine has tetanus. So when they are given that normal schedule, they don't have to get it again for any wound, because they have already taken the normal schedule. If they have taken the scheduled vaccines, there's no need to repeat.
Madam, then there's another question. In general practice, instead of amoxicillin, can we use cefalexin?
Yeah, I mean, it's like this, amoxicillin and cefalexin, for certain infections, yes. But there are like, okay, maybe certain, there's little difference only. Like, for example, the cefalexin has more gram-positive cover. Even amoxicillin now has gram-positive cover. But like if it's a urine infection with enterococci or something, only that you may have a problem where amoxicillin, cefalexin may not be useful. Otherwise, there's no big difference. So, like a streptococcus, for a streptococcus or a staphylococcus infection, staphylococcus, of course, you need flucloxacillin. But for a small, like a now sore throat or so certain other things, cefalexin is as good as amoxicillin. There's no big difference.
And there's a comment, one combination of antibiotics will increase the resistance.
Combination in the sense, like usually we don't recommend combinations. Just there should be a need. I mean, there are only certain situations where combinations are recommended. That is, like we know that in endocarditis, in the hospitals, we give combinations because there are guidelines showing. Still, evidence is very minimal, but there are evidence. There's evidence that combinations with beta lactam and aminoglycosides are recommended for endocarditis, which has a like a higher killing power, like a synergy. But otherwise, combination is not recommended because there can be like side effects and interactions. But the problem that you're asking is increase the resistance. Uh, I can't say increasing the resistance. Sometimes actually we combine to reduce the resistance. Like for example, now in TB. TB, we give 4 drugs together because there's a high chance if you give only one drug, there can be one resistance develop into that. So that is why we combine. So it's the other way around usually, but it's only for certain infections. For certain infections, the combinations are recommended to reduce the chance of development of resistance so that if there's a mechanism of resistance which will be affecting one, the other one can kill this one. So that all the whole group can attack and kill the bacteria so that there won't be anyone left behind.
Madam, there's another one. How do you treat persistent asymptomatic bacteria?
Yeah, persistent in the sense what you mean is probably after treatment if you still have the same thing. So it is only important, as I said, only in pregnancy or if you are awaiting GU surgery. So in certain GU procedures, I have noticed sometimes if it is not going away, especially in patients like what I have noticed is like people who have stents. If there's a stent inside and if there's some bacteria or even candida colonizing the stent, then it's very difficult to get rid of it. So all the time the urine cultures will become positive because it's on that stent. So in that situation, sometimes you may have to do it under maybe a prophylaxis, which is effective for that, and do the procedure. So I said no, only in certain the pregnancy. Usually, then there's no other way that, I mean, no point giving different antibiotics one after the other if it's not effective. Then best is to I think do other preventive measures and carefully monitor, and if there's an infection immediately treat. But usually in pregnancy I have not seen this as a problem very much, but I don't know whether you have had that experience.
Madam, what's the duration of gap for a TT vaccine after ADT?
After ADT, that means uh, you mean if you have an exposure, probably when there's a,
Most
yeah,
probably.
usually, yeah, they now what they say is you need not give it unless there's a like a 10-year of gap. You don't usually recommend vaccines now because they say five now. Even if you have got the childhood vaccination and then the ADT also, it's usually until about 10 years you shouldn't you need not revaccinate.
Madam, when a patient comes with diarrhea more than 6 to 7 times, even in first day, is it needed for antibiotics prescription?
No, it doesn't depend on the times, like the number of times that the patient has diarrhea, because it could be still, I mean, managed with the important thing is to replace the fluid and the electrolytes. Then then we have to see like if he's systemically becoming ill or something, only you have to think of whether it could be a bacterial infection, and some maybe if it's a neonate or a very immunosuppressed person or somebody, then you may give antibiotics after maybe taking even blood cultures if there's a fever and other systemically unwell person, because otherwise the number of episodes of diarrhea is not a problem. What you have to do is you have to replace the fluid and the electrolytes. That's the important.
Madam, there's another one. In general practice, what are the occasions should give tetanus toxide? If once given, how prolonged patient is safe?
Yeah, that is, I think, the same thing that we discussed earlier, no? That
Yeah.
tetanus toxide, usually we shouldn't repeat too often. Now they said too many doses of tetanus toxide is also not good. So they are not allowing to give like, because initial course is enough, and then you need not repeat it very often.
Then time gap for repeat the urine culture in asymptomatic urine culture positives.
Yeah, actually, there's no specific time gap that I have seen for the pregnancy, I think. So usually the recommendation is that you do it and then treat it, and if it is not there, probably you can I have not seen a proper guidelines as such because with time they will not hopefully not recolonize. So I mean colonization would anyway be there, but asymptomatic bacteria there's no proper. As far as I know, there's no proper guideline to repeat it.
A lot of questions regarding tetanus, madam. Like when giving tetanus toxoid, do we have to give 3 doses always to adults, or is it not necessary now, and the dosing frequency?
Yeah, I think now I will read this. I think our immunization Sri Lankan guideline. There was a schedule. No, there's no special schedule, but uh, usually what in adults, I think they have not. If you have got 3 or more doses, what this guideline says is uh, for 30 tetanus prone wounds, give tetanus toxin more than 5 years since last booster. No, if there's no more than 5 years, no, no immunoglobulin. Then after more than 10 years, then you have they are giving immunoglobulin also. But then doses, of course. Give only. I will share the guideline. I think I have not seen the Sri Lankan guideline, especially. I think there's a vaccine book separately, which we can refer. I will. I mean, I can share that with y'all if you all have not come across that. I think what they say now is not to give it for a long like so many doses, but I can't exactly give the number of doses. Uh, Shall I share it later?
Okay, madam. Like for cellulitis, we see doxycycline and cipro given orally at GP practice as it has anti-inflammatory property. Is it advisable to reduce swelling?
Doxycycline and Cipro.
Cipro.
Those are not recommended.
Okay.
I have not I have not seen any guideline because Cipro doesn't have even a streptococcal cover. So that's I don't know where from where they have got that
Can IV antibiotics affect the child's growth?
growth. I mean I I can't exactly. I don't have any. I have not come across any situation where it can affect the growth. Only place is like no, but usually I don't think I have got any evidence. Have you read? I don't know whether that person has read anywhere. But I have not come across anything like that. Not for the growth.
If patients are on immunosuppressants or biologics, can we wait without treating for asymptomatic bacteriuria?
No, the immunosuppressed. No, immunosuppression. I mean, in the sense like. But the problem is in immunosuppress, if you start just treating, immunosuppression is a very broad term. So if all are having diabetes and all are having like maybe like CKD or somebody may have CKD. So if can you finish treating asymptomatic bacteria? That's the problem. Like whether you can get rid of it because these patients invariably will have more and more courses of antibiotics and then their flora become more and more resistant. So those groups we see, sometimes there's nothing to treat. When they really get an infection, they have nothing to treat. We don't have any antibiotics to treat them. So that is another major problem that we have come across. So I think best is not to give anything unless they are really having infection because they are a very complicated group. Like if you really look at most of these immunosuppressed patients, like cancer patients, chemotherapy, they have had many courses of antibiotics and they are already having multi-resistant organisms. So how many times to treat? Like it's not really rational.
Madam, if a patient with mild prostanomegaly without any significant postvoidal volume getting recurrent UTI, does he need prophylactic antibiotics?
No. Prophylactic antibiotics does not work. for adults, there's no recommendation. We have seen plenty of times, like people do give. I have seen even some specialists giving antibiotic prophylaxis to adults, but they come back with infections. It doesn't prevent. There's no
Madam,
evidence for that. Yeah.
then some operation theatres have suboptimal conditions. In clean surgeries, that antibiotic prophylaxis is not necessary. Do prophylaxis give benefits in these situations?
In certain clean surgeries, they have recommended, but you have to give, there are recommendations because, I mean, we are practicing evidence-based medicine. So, but I know the evidence is limited. Some studies may not have been done, but uh, of course, it has to be given. You can't just, one thing is now, for you have to do it properly, like antibiotic now theater conditions. Okay, theater conditions, if they are not good, there can be problems. But can the antibiotic prophylaxis prevent? You mean what he is asking is with for anti to give it to other surgeries which where the antibiotic prophylaxis is not recommended, no? Maybe, no? That of course, now say for example, now, practices that I have mentioned, like the vaginal delivery, they give it after delivery. So that will not help at all, because now probably they think that it will help to heal the episiotomy. But episiotomy is already closed and sutured. So usually they don't recommend prophylaxis to be given after that. It has to be given at the surgery for these indicated surgeries, but not for other surgeries. So there's always a risk and benefit. So by evaluating that only, they have said not to give. But and prolonged therapy is always having risks rather than benefits, because they will promote development of resistance. So unnecessary prolonged treatment will not help. Now the argument that the theaters are not good and therefore we are giving for 5 days or 10 days of antibiotics for surgery is not valid, because if the theater was not good, and if the organisms have entered the wound at that point, that is why that they usually they at the surgery they recommend 1 dose just to have the antibiotic level in the blood by the time of the surgery, so that antibiotics will they will go into the site and be there, like antibiotics will be there in the field of surgery, surgical site, so that when it is open and when they do the surgery, when the bacteria falls, they will kill it. But after that, if you continue, their flora will become resistant, and then whatever you are giving will not be effective. If you continue it for a long time, it doesn't have an effect. So that is why the recommendations have to be followed, because that's the evidence. So we can't just modify things saying that our theaters are not good, therefore we are giving a meropenem or something for prophylaxis. That doesn't work. Then it will make things worse.
Madam, can we continue vaccines when the babies are on steroids?
Yeah, there's no contraindication for that. Yeah. Even the thing is, immunosuppressed babies, not steroids, but live vaccines are not usually recommended for immunosuppressed patients. Like if they have, like in pregnancy, we can't give live vaccines because it can affect the baby. So live vaccines are not recommended, but others you can.
Madam, can you please repeat the name of the app regarding drugs?
Sanford, yeah, I can share that also. I will, shall I send it to you? Sanford app, SANFORD. It has nice calculations and everything. Yeah.
Madam, does ciprofloxacin affect growth of children?
Ciprofloxacin, actually, the evidence is in puppies. There are some studies showing it can affect the joints, right? But actually, in children, sometimes they have been used and there was no effect. So therefore now it is not a contraindication. They say in children you may use it like, I mean, their doses are given now for children. So, but still we avoid because unless it's really necessary. But that is not a major threat now. There's no big evidence for that in humans.
What are the recommended oral antibiotic or combination for contaminated wound if deep and needs suturing?
Antibiotics. Uh, Amoxicillin clavulanate is more than enough. Or even actually, it depends on where the wound is. Like usually, even flucloxacillin is enough because it's a staphylococcus that is usually. But amoxicillin clavulanate will have anaerobic cover as well. If it's very highly contaminated, you may use amoxicillin clavulanate.
In recurrent UTI of patient with indwelling catheter can start prophylactic antibiotics.
Sorry, indwelling catheter.
If the patient is with the indwelling catheter, can start prophylactic antibiotics.
No, no, not at all. No, it will not help. No, because again, that same principle. Because then your flora will become. You can't just get rid of all the bacteria by giving antibiotic. That's the thing you must remember. Whatever antibiotic we give, even meropenem, when we give meropenem, now we have seen in ICU patients where we treated with meropenem or colistin or some things like that. Now there are Klebsiella pneumoniae which are resistant basically to everything. Klebsiella resistant to every antibiotic that we have had been reported in Sri Lankan hospitals. So therefore, by just continuing antibiotics, we can't prevent infection. That is important to be remembered.
What is the best antibiotic for infective diarrhea?
It depends. Like infective means like there are so many types. No, Salmonella, Shigella is common in Sri Lanka probably, but Shigella is not much seen now. So Salmonella, fortunately, is not resistant in most of situation. There are some now, some which are resistant to cephalosporins, which had been reported from some hospitals. But all in all, quinolones or cephalosporins are effective for that. But there are certain things like Campylobacter and other infective diarrheas which will need something like erythromycin or quinolone. So there are depends on the situation. So based on what sort of history, like with the history, you have to probably suspect now. Campylobacter is you think that it is not common here because we cook the meat very well, but found in the chicken. We have There are reports that it is there in chicken. So in case there's a contamination in the fridge or something, you can still have diarrhea with Campylobacter and things like that also. Otherwise, something like even a cephaloxin would be enough for most of the Salmonella still are sensitive. But Salmonella, again, as I said earlier, mild diarrhea need not be treated with antibiotics even. You can just give the symptomatic treatment and it will resolve.
Any recommendations to prevent mist infections other than universal precautions?
Sorry? Any
Any recommendations to prevent mist infections other than universal precautions?
mixed infections. What do you
Mesh
mean by
infections, madam.
ah? A
Mesh
mesh.
infections.
Mesh means in the like is it mesh infections in what sort of patients?
Mesh infections other than universal precautions.
That means maybe hernia, is it? A
It's not very clear, madam.
Sanford guide, somebody had, yes, that's the one. Yes. Somebody had put the
Yes.
link there. Good. Yeah, you can download this and use in your phone. Yes. Uh, yes. So, sorry. Yes. That's,
Madam, he's asking about proline mesh getting infected.
Yeah, if it is infected, what is the question? With what antibiotic to give?
Uh,
No,
uh,
I can't see the question now.
if the proline mesh is infections other than universal precautions, how to prevent it?
Prevent infection.
Yes, madam.
So this is in surgery, no?
Yes.
So there are, yeah, I suppose, I mean, one thing is prophylaxis can be given at that point, and then, like theater conditions, uh, like especially when you put some artificial thing, even a mesh or a joint or anything like that in a surgery, you have to be very careful because even the normally non-virulent sort of organism like one maybe coagulase negative staph that we talk about, not only Staph aureus, the less virulent organisms also can adhere to this these plastic or metal things when you insert in a body of a patient. If there's a little bit of contamination even from the environment, they can cause problems because they can form biofilms and they can cause infections. Little by little, they may multiply on the surface of the mesh or whatever you put, because it may act as a sort of a prosthetic artificial material that may be a very good niche for them to like adhere to and make a biofilm and multiply within that, and our antibiotics may not work if for treatment. So therefore, in that situation, the antibiotic prophylaxis can be given, but you should not continue it. It has to be given within the 60 minutes. Within 1 hour of the surgery, it has to be given before the surgery, just before, like at the induction of surgery. And the theater conditions have to be good so that there shouldn't be overcrowding. There should be like very good to have a airflow, like air changers in the theater, rather than just having a AC somewhere, slit air sampler or something, air conditioner, because those are not making the air movements like flow. So air changes are important, and then have a proper, reduce the number of people in the theater and have a good attire so that you cover. All those are very important. So they are like recommended for this sort of surgery, and especially maybe like these things we are inserting, you have to take special precautions in the theater to prevent any contamination and to have a good environment in the theater and to have prophylaxis. So, I mean, you can't compromise the theater conditions and say, okay, because the theater conditions is not good, we are giving antibiotics to prevent for a long time, antibiotic for a long time, or broad antibiotic. That doesn't work because it doesn't work. If the theater is not good, whatever the antibiotic you go, best brand, best antibiotic will not work. You will still get an infection. So that is the important thing. So theater conditions have to be followed. And the way you practice the aseptic conditions, the scrubbing, how you scrub, how you use your sterile attire, all that is important. Instrument sterilization. Yeah. Usually
Madam,
standard. Yeah, sorry. Yes.
Madam, when diabetic patient came with respiratory infection, is it recommended to use prophylactic antibiotic? If it's so, what is the recommended one?
Diabetic patients came with respiratory infection. It's recommended to. No prophylaxis. No. You mean no. There are certain patients where we are at a lower threshold to give an antibiotic in a respiratory infection. That is in the patients who have like uh, chronic respiratory problems or they are having heart failure. Then you may sometimes have a tendency to give without very lower threshold to give antibiotics. But diabetics also, yeah, it may be if they have a very uncontrolled diabetes and if their immunity is low, you may think of that. But there's no prophylaxis, but have a low threshold to start antibiotics because it's very difficult to differentiate whether it's bacterial or not sometimes. So it may be okay, but it is amoxicillin or amoxicillin clavulanic is adequate. still, because there's no reason why they should have more resistant bacteria causing any respiratory infection. Respiratory infections are usually with pneumococci. If it's a community-acquired pneumonia, we are not talking about hospital-acquired pneumonia, I hope, because if it's in the hospital and if it's after ventilation and being in the ICU, their flora will be different. If the patient had been in the ICU or in the hospital and got this infection and already had been on antibiotics, then their flora would be already resistant, and then what they get, the next infection would be definitely more resistant bacteria. Gram negatives can be there then. But otherwise, if it's a common infection which is coming from the community, mostly it is Streptococcus pneumoniae, or if it's a post-viral, there may be Staph aureus. Otherwise, it's a very rarely Haemophilus influenzae and very rarely Klebsiella pneumoniae. But then you can identify, like Klebsiella pneumonia will be very severe, and there will be like the different type of phlegm would be like sometimes they say like red color sputum and all that can be there. So it will be a severe pneumonia. Then if the patient is in the hospital, then they will have to start again, but mostly 4-amoxiclav is enough.
Madam, what is effects of probiotics?
Effects of probiotics. It's like this. There's no big evidence that probiotics will help even in the C. diff diarrhea or any, because we feel that if it is due to the replacement of the normal flora, that probiotics will help. But I think the evidence is still very poor. But we give, I mean, it's not doing any harm. So in diarrhea or patients who have any problem, gastric, like GI problems after antibiotics, we usually give it. But it is probably it's not worth giving it with another antibiotic because it will again get destroyed. What you give is not effective, uh, but otherwise it may be good, but there's no big evidence.
Madam, is there a guideline to prevent infections in mortuary?
Infection prevention in mortuary, yes. There's a book that we have. You probably now in the same website that I showed, the Sri Lanka College of Microbiologist website, we have another manual for infection prevention and control. So in that we have a special section for mortuary as well, I'm sure, because there are like certain preventive measures we have to take.
Madam, using cotrimazole for diarrheal infection, what is your view?
Clotrimazole or clotrimazole?
Clotrimazole, madam.
Maybe cotrimoxazole, no?
Clotrimazole.
Cotrimoxazole. Yeah, cotrimoxazole usually we don't use directly. We have not recommended for diarrhea. Mm, for what I don't know who uses it, but there's no. I don't think guidelines have it as a common thing. Cotrimoxazole in some countries are kept only for pneumocystis pneumonia. So there are certain, I don't think it should be used very often, but. Trimethoprim is used as a single agent. In Sri Lanka, we don't have it, but in other countries, trimethoprim is used for UTI, but not for diarrhea as per se.
We have addressed many questions of the that were sent through the chat box today. I would like to make a brief announcement before we conclude. As mentioned at the beginning of the session, all participants who registered will receive their CPD certificate. The attendance details will be forwarded to the ETR branch of the Ministry of Health, and once the necessary notifications are completed, the corresponding eCPD certificate will be sent to your registered email address within 2 weeks. We have now come to the end of today's session. Once again, I would like to extend my sincere gratitude to Dr. Kushlani Jayatilleke for the valuable presentation, and thank each and every one of you for joining us this evening and actively participating. Have a pleasant evening and good night.
Bye.
Good night.
Good night.
Thank you, madam.